ഡെവിൻ എൻ്റെ സ്റ്റുഡൻ്റ് ആയിരുന്നു. അപ്പോൾ ഞാനിങ്ങനെ അതിശയിക്കുമായിരുന്നു. ഡെവിൻ്റെ അടുത്ത് ഞാൻ എപ്പോഴും സ്നേഹത്തോടെ മാത്രമേ പെരുമാറിയിട്ടുള്ളൂ. അപ്പോൾ ഈ സഹദുള്ള സാറിന് ശേഷം എനിക്ക് എന്തിനീ ടോക്ക് തന്നു ഞാൻ അതിശയിക്കുമായിരുന്നു. Can I will be nobody here. Anyway, I am not going to speak about management. I am going to speak about diabetes care. And Devin was so particular that we should have at least 10 minutes for diabetes care when we are having a QPMBA meeting. Since this is a topic which is so important. But laptop illennu thonnalle. So can I see the slides? അല്ലേ സൈഡ് എങ്ങനെ കാണാം? അങ്ങോട്ട് നോക്കി പറയാം. ഓക്കെ ഫൈൻ നോ പ്രോബ്ലം. And this is a very, very brief lecture, and fortunately or unfortunately, I meet a lot of doctors and hospital staff and pharmaceutical friends as patients. And every week there is a new doctor coming to me at one of our hospitals. And this is a doctor who can be my own teacher, or this is a doctor who used to be my student or a colleague. And this is a classical one, a 62-year-old professor. And you can see the prescription over there, the A1C over there. It is extremely on the highest side. It's fairly on the highest side. And this doctor is on a combination, is on a dosage which is probably not recommended. A very high dose of insulin. And this combination is also not a recommended combination. It's not there in the guidelines. Why is it happening? And yesterday, I was in Bangalore. I reached Trivandrum only today morning. We were having an International Diabetes Federation meeting in Bangalore. And we discussed about the necessity of teaching, training, and counseling the doctors. Every year, more than 90,000 doctors are passing out in India. And most of the doctors in many of the specialties, they are rather forced to treat diabetes. The doctors can be in ENT, the doctors can be in general surgery, doctors can be in orthopedics, but they are forced to treat by their patients. They are forced to treat diabetes. And the treatment of diabetes has completely transformed during the past more than 20 years. And this is based on the modern medicine evidence, because you know that the modern medicine is completely different from the traditional medicines, because we generate evidence from the clinical trials. And we stood with the doctor, and the doctor came along with his son, because that is very important for us. The doctor should never come alone with us. So when the doctor is visiting the hospital, they should be coming along with some other close relative or a caretaker. And we discussed about the newer therapies. We discussed about elimination of hypoglycemia, because the doctor was so busy with practice and also teaching and with the students. And we started continuous glucose monitoring. Continuous glucose monitoring is one of the standard of therapy. Because yesterday we were listening to Narayana Murthy of Infosys, the co-founder of Infosys. A very elegant lecture followed by a question answer session at Bangalore, in the program that we organized at Bangalore by the International Diabetes Federation. And he himself was wearing a Freestyle Libre 3. He is getting it from US, and in India we are having Freestyle Libre 3 for the last 7 years. And the continuous glucose monitoring we started using from 2004 onwards. And very sad that whenever we meet doctors or their very close relatives, many of them are unaware of the fact that all these devices, 90% of the devices are already available and used by the patients in India. And from a whooping, you have seen the A1C, the 3 months average of more than 10%. Within the next 3 to 4 months, we could reach a A1C target, a time in range target of 84%. So we no longer use hemoglobin A1C as the end point in diabetes. We are using the time in range. The metrics will be time in range, below range, and above range. And another doctor, I used to meet him very frequently, almost every month in one of the conferences. He will be there to listen to my lecture. So some of you may not be knowing, I started my career as a assistant professor in Trivandrum Medical College. I was working in medical college for more than 10 years. ഒരു പ്രത്യേക സാഹചര്യത്തിൽ എനിക്ക് മെഡിക്കൽ കോളേജിൽ പോകേണ്ടി വന്നു. അത് കഴിഞ്ഞ് ഞാൻ US-ലായിരുന്നു. തിരിച്ചു വന്നപ്പോഴത്തേക്ക് 40 വയസ്സിൽ താഴെ പ്രായമായതുകൊണ്ട് എന്നെ ഏൽപ്പിച്ചൊരു ജോലി എനിക്ക് തുടരാൻ സാധിക്കില്ല എന്ന് കുറേ പേര് ചേർന്ന് തീരുമാനിച്ചപ്പോൾ നിവൃത്തിയില്ലാതെ ഞാൻ സർക്കാർ ജോലി ഉപേക്ഷിച്ച ഒരാളാണ്. അത് കഴിഞ്ഞ് ഐ ഹാവ് എ ഡിഫറെൻറ്റ് മോഡൽ. So I listened to Ashokan sir and the family, Sahudullah sir, discussing about different models. My model of starting a hospital, because I am not an entrepreneur. I am just a clinician and now I am a researcher. So I started a hospital with patients. Actually, some of my patients supported me, and then we formed a private limited company and started a hospital. And primarily now the hospital is a research center. And we are the International Diabetes Federation accredited center in Kerala. And we are also running courses for doctors, a 2-year course for MBBS doctors in diabetes. This doctor, when we are discussing, he doesn't have time. He doesn't have time to monitor. He doesn't have time to sit with me. He doesn't have the time to spend time with the family. And his A1C is remaining more than 11% for more than 5 years. What happens? If the A1C is remaining high, this is a natural history of diabetes, which happens to more than, I would say, more than 50% of. We keep on telling. The Indian Medical Association, our beloved Vice Chancellor is here. Doctors, we have a life expectancy which is usually lesser, 10 years less compared to the general population. Why? Why? This is a natural history. After hypertension, diabetes is the number 1 killer. After hypertension, number 1 killer. And this is a natural history. Erectile dysfunction, the onset of first coronary artery disease, followed by chronic kidney disease, and then there is another episode of a coronary artery disease, and then end-stage renal failure, multiple infections, multi-organ failure, and death. And this happens usually 10 to 15 years earlier when compared to general population because of multiple risk factors. And the situation is quite alarming, and we have done multiple surveys during our JPF. In the International Global Convention that we organized, that was the 11th year of our convention last month, more than 1,233 doctors participated. And we did a survey. It is alarming. The situation is very alarming. The management protocol is changing. And we have our the organization India, and I am an executive member of this organization. RSSDI is only second to the American Diabetes Association. We will be soon overtaking the American Diabetes Association. We are also having the guidelines for India. So there is a country-specific guidelines. Sometimes the doctors are worried about following the guidelines of the American Diabetes Association. And these are the guidelines which are evolved out of studies done in Caucasian population. No, it's not like that. We have our own guidelines, and this is the guidelines which are evolved out of our own original publications from across multiple centers in India. Look at the red colors over there. This is ACE, this is the ADA, multiple guidelines. Sulfonylureas are no longer recommended. Glimepiride, glibenclamide, glipizide, these are no longer recommended in the management of diabetes for more than 10 years now, for multiple reasons, which I don't have the time. And you have to go by the decision cycle. And the decision cycle will have multiple components, similar to what Sagadullah sir has described in the management, how to manage a family, how to manage a team. This is how you have to manage a patient with diabetes. Counseling them, training them, home blood pressure monitoring, home glucose monitoring, and then periodic telemedicine consultations, and the lab investigations to be repeated once in 3 months, continuous glucose monitoring to be repeated based on clinical judgment. And you have to assess, very important, some of the other parameters which can be a major contributor to the early death of an individual. The duration of sleep. The duration of sleep, if it is more than 8 hours or less than 6 hours, is inadequate. If you have a smartwatch, you can assess the quality of sleep. You can assess the duration of sleep. You can assess the time which is spent in deep sleep, the time which is spent awake. നല്ലൊരു സ്മാർട്ട് വാച്ച് നമ്മൾ ഉപയോഗിക്കുകയാണെങ്കിൽ ഇതെല്ലാം നമുക്ക് easily you can assess. Very easily you can assess. And this is going to have a direct impact on your blood pressure, direct impact on atherosclerosis, endothelial dysfunction, and so on. And then irregular sleeps, and then you have 3 different chronotypes: early chronotype, normal chronotype, late chronotype. And then an increase of just 500 steps per day is associated with 2 to 9% reduced risk of cardiovascular and all-cause mortality. A 5 to 6 minutes brisk intensity walk per day, that equates to 4 years higher life expectancy. And for diabetes, we have specifics over there. And even without diabetes, you have to have at least 150 minutes of physical activity, moderate physical activity in a week, and 2 days have to be spent for muscle training. Because now sarcopenia is a major issue. Sarcopenia, other treatment is with muscle strengthening. At least 2 days a week you have to spend time for muscle strengthening, weight training exercises. And then you have an armament here. For the last more than 13 to 15 years, we have a group of drugs such as the GLP-1 receptor agonists, we have SGLT2 inhibitors. Many of them are now available as generics. Liraglutide is going to be available soon as a biosimilar. I agree that some of them are very, very expensive even for the doctors. But I have seen even the doctors themselves using older therapies, where none of the organizations, whether it is a national Indian organization or the international scientific organizations, they are no longer recommending. They are no longer recommending because the newer agents are not meant for glucose reduction. The newer agents are meant for cardio-renal protection. They are the ones which are proven in cardiovascular and renal, randomized clinical trials, dedicated RCTs to have cardiovascular superiority. Many agents are meant for reducing dementia, even prevention of Parkinson's disease. So many of them are having multiple pleiotropic benefits. And monitoring is the key factor. So we have to go by the guidelines on monitoring. So we have the guidelines published for India in type 1, type 2. And this is a spaces slide, just for information from our family. We are currently also publishing an international journal, and this is published by Walters Kluwer, and it is with an international editorial board. 70% dedicated for technologies and 30% dedicated for diabetes. And this is about the older ones, because we are used to monitoring glucose with glucose meters. But currently, for the last more than 5 years, the gold standard is to use the connected glucose meters, which comes with no extra cost. Absolutely no extra cost. I don't know how to, because this is a video, you have to click and then only, can you click on the video? And this is a connected glucose meter where the glucometer gets connected via Bluetooth, available in India for more than 7 years from multiple international brands such as Roche, from One Touch family, and you can create a digital glucose diary. So when you are visiting the doctor or when you are managing your own diabetes, a pre-meal value, a 2-hour post-meal value. So all of these are possibly the connected glucose meters. It doesn't matter. And the gold standard now is to go for continuous glucose monitoring, available for more than 15 years, and now they are trouble-free. And I used to say, if the doctors are not recommending the connected glucose meters, if the doctors are not recommended the continuous glucose monitoring devices, the patients are going to use it. So I used to communicate with the device manufacturers, because with all humbleness, let me tell you that I am one of the advisors for all these devices, and I chair the global board for them. And according to them, in India, the patients are procuring it online rather than the doctors recommending it. So if you are using the continuous glucose monitoring devices, it is going to completely change the way. There is a paradigm shift in the way you manage diabetes. And the patients themselves can be empowered to manage diabetes without enhancing the dosages of drugs. They will themselves find out their diet, their exercise. They may be eating more carb. Still, the hemoglobin A1C will be below 7%. So these are the new standards in care. You can look at the graph. I will make it very simple. I will make it very brief. The normal value for those without complications, the lower limit is 70%, and the upper limit is 180 milligrams per deciliter. So you look at the first bar one, that is the commonest one, where there are no serious comorbidities, where the time within range need to be more than 70%. The time which is spent between 70 and 180 milligrams per deciliter should be more than 70% in 24 hours, which translates to 17 hours in 24 hours. And the time below range can be level 1 and level 2, which is more dangerous, below 70 and below 55 or below 54. And no patient, I will say, should have a time below range. The maximum permitted one is less than 4%. That is a time below 70. And if somebody is susceptible for comorbidities and susceptible for hypoglycemia, then you aim for not 70%, you aim for just more than 50%. Because if you aim for more than 70% or more than 60%, if the patient is or the subject is susceptible for hypo-induced complications, they may die soon, or they may succumb to multiple other complications. So you have to customize, and the era is for personalized diabetes care, where every person with diabetes is different. And this is the one for the South Asia. We have the South Asian recommendations from an international panel, including the IDF and the ADF president. And this is with respect to considering our own limited resources, because CGM is something which is reimbursed and provided free of cost in the developed countries. Here we cannot do. And so we have our own recommendations, and for children with type 1 diabetes, those with uncontrolled type 2 diabetes, we have for the last 3 years, we have the completely automated insulin delivery devices. And these are the automated insulin delivery devices which can provide you with 100% time in range. So whenever the glucose is falling low, the insulin will be reduced, the dosages will be reduced, and if there is further tendency for a hypo, the insulin delivery will be completely stopped. And if you are forgetting to deliver a bolus dose of insulin, the delivery device automatically delivers insulin bolus. And the basal insulin also keeps on changing once in every 5 minutes. So all these devices are available in our country. In one of the programs where I attended along with the gastroenterology group, they were removing the pancreas for a particular reason, and somebody was telling, after removing the pancreas, we are finding it extremely difficult or rather impossible to treat diabetes. And the entire group was unaware of the fact that these devices are available. Even for the affordable, they were not recommending the device. So this is my concluding slide. I don't believe that the doctors are bad patients. Teachers and doctors are bad patients. I don't believe so. Doctors are also good patients. Physically, please meet your doctor. Don't treat yourself. At least meet 3 times in a year. And try to update the knowledge, and the updated knowledge should be translated to your patients, and also try to have it for your own and for your dear and near ones. And when you are involved in a chronic care, such as a treatment for a disease which is lifelong, never meet the diabetes team. Diabetes is not treated by the doctor. Diabetes is treated by a team consisting of dietitians, diabetes educators, nurses, and so on. There will be minimum 6 members in a team. Don't meet the team alone. Meet the team along with the responsible person. It can even be your driver if none is available. And plan your chronic care. ഞാൻ പറഞ്ഞ എല്ലാ parameters, it is based on the remaining years of fruitful life expectancy. So plan the chronic care based on the remaining years of life expectancy. So thank you very much. And this is the announcement of JPF in 2024. And this is scheduled on 12, 13, and 14. And this is going to be the 12th year. So thank you once again, Dr. Devin, Prabhakar, and give me an opportunity to be part of this elite group. Thank you.